Good afternoon and welcome to a Fireside chat with Dr. Anthony Greco, where he'll be discussing managing metastatic patients with unclear diagnosis. Please note that we are going to be recording today's presentation, so if you do not wish to be recorded, you may choose to leave the meeting at this time. If you remain, you are consenting to be recorded. The Fireside chat with Dr. Anthony Greco, we are going to be discussing managing metastatic patients with unclear diagnosis. He will be covering perspectives on the management of metastatic patients with unclear diagnosis, approaches to personalized medicine, is it effective to treat based on a molecular alteration alone? And then at the end, we are going to have an open forum for discussion. Now, you'll notice at the bottom of your screen, you have a chat icon. If you click on the chat icon, you'll be able to type in your questions for Dr. Greco. Please use that format, as everybody on the call will be muted today, and I will be recording those questions and asking them at the end of this presentation. Dr. Greco is the co-founder of the Sarah Cannon Research Institute. He is a practicing medical oncologist at Tennessee Oncology. He's the past director of medical oncology in Vanderbilt Cancer Center at Vanderbilt University Medical Center, and the past director of the Sarah Cannon Cancer Center and Sarah Cannon Research Institute. And he is also a medical advisor for biotheranostics. Dr. Greco, feel free to start your presentation.
Thank you very much. It's a pleasure to be able to discuss this important issue today. We're dealing with the problem of patients with metastatic cancer, which is a huge problem in the United States and the world. This slide illustrates to you the group of patients with advanced metastatic cancer, the majority of which are fairly easy to recognize. They have metastatic disease, and we can find the primary site by clinical examination. The group of patients I'll primarily be talking about today are that group in which the primary site is not obvious despite rather extensive testing. This is 2 to 3% of all patients with metastatic cancer, amounting to anywhere from 50 to 100,000 patients a year in the United States alone. In many respects, there are similarities of managing patients with metastatic cancer, regardless of whether the anatomical primary site is found. And obviously, one needs a biopsy. And usually the biopsy will give the diagnosis of malignancy or cancer. And then in particular, those patients with an unknown primary where we can't find the actual primary site, yet the patient has metastatic disease, we often need additional pathology, including immunohistochemical stains and an important molecular test, in this case, the RT-PCR cancer type ID. Often with this information, we can then come to a single tissue diagnosis, single cancer type diagnosis in most of the patients, 90 to 95%. Once we know this, then we go over to the track that we normally take in patients where we have a known primary site. And that would include additional testing for that particular cancer type, which may include markers, genetic markers, additional blood testing, and then appropriate treatment for such a patient. So the treatment of patients without an anatomical primary site, so-called CUP, cancer of unknown primary site, in essence becomes similar to groups of patients with known primary site. There are some patients, however, where we cannot determine a tissue of origin. This is only a minority, probably around 5 to 10% at the most. In this group of patients, we can use empiric chemotherapy that's been around for several decades. We can use clinical trials, and often we can use comprehensive molecular profiling to perhaps find some target or treatment that might be appropriate for selected patients. Now, when we talk about cancer of unknown primary site, it's very important to know the tissue of origin. because there are many types of cancer that present this way, we don't understand yet why the primary doesn't grow large enough to be identified, nor why it produces metastasis, which do become large enough. And that's usually where the biopsy comes from. We know that the cancer type ID is an important genetic test because it can determine the cancer type, particularly when used in concert with clinical features and at times immunohistochemistry. We can then determine the cancer type. We can do, in some patients, additional molecular testing based upon that cancer type, usually in next generation sequencing, or in some patients, hotspot genetic testing for particular genetic alterations associated with that cancer type. Appropriate treatment for this cancer type, once determined, depends on a specific diagnosis. As mentioned, the CUP syndrome is unique and appears to be a small subset of many specific cancer types with very small anatomical primary sites, but with the ability to metastasize. The explanation of why the small invasive primary does not grow large and why metastases develop and grow remains unknown, but likely involves epigenetic and genetic mechanisms which are actively being investigated. How do we know that patients have a primary site? Well, this has been determined over the years from autopsy studies. When one looks at autopsies in patients with cancer of unknown primary site, 75% of the primaries are indeed found at autopsy. These are often small. Many of these are less than 1 centimeter, but they're invasive cancers. And there have been over 25 different primary sites found at autopsy. Now, autopsy has limitation in finding very small primaries in the breast, the liver, intestinal tract, urinary tract, and others. It would require hundreds, perhaps thousands of sections to be made through these organs. And this is why I think that the percentage of patients who have an anatomical primary site is much larger than 75%. It probably approaches 100%. So these patients have a primary. It's too small to find in most patients, and yet they have metastasis. And we can determine the tissue of origin by appropriate evaluation. Now, there are some major questions about cancer of unknown primary site. Obviously, this is a clinical entity, and it does have a unique biology. At least most of us think that it does, and I've been talking about that, the ability to metastasize yet be too small to find. Some people think, I'm not one of those, that this is a single type of cancer, akin to other types of cancer known as cancer of unknown primary site. All the available information suggests that this is not the case and that this represents many types of cancer with the ability to metastasize. Again, the reason for this syndrome is still relatively obscure. We don't know why this happens. Does the diagnosis of the tissue of origin by immunohistochemistry and/or the cancer type ID and site-specific therapy improve patient outcomes? Again, the answer is yes and no. It depends on what type of cancer is diagnosed. This is changing almost weekly, certainly yearly. Those with sensitive cancer types, and I can name a few: renal cancer with various treatments, colorectal cancer, lung cancer that present as CUP, or cancer of unknown primary site. We've learned we can treat those patients, and they do much better when we use site-specific treatment. On the other hand, there are a number of very unresponsive cancer types that we can't treat very well, even with their therapies that have been evaluated, include pancreatobiliary cancers and others, where we wouldn't expect them to do any better, even if we learn what they actually had. And this is changing because as treatment improves for these types of relatively unresponsive cancer types, then knowing the cancer type becomes very important. The third question: does comprehensive molecular profiling next generation sequencing, where one is looking for genetic alterations in the cancer cells, does that lead to information and precision therapy? In some instances, the answer is yes. In many instances, the answer is no. Once again, this depends on the cellular context or the tissue of origin. Certainly in some tissue types, for example, non-small cell lung cancer, is very important in that tissue of origin in a patient who presents as CUP to look for various molecular alterations which have important therapeutic implications, such as epidermal growth factor receptors presence or ALK rearrangements and ROS1 rearrangements and others. So it certainly has value there. Is it useful in the initial treatment of most patients with CUP? No, it's not, because right now we aren't using targeted therapy for the majority of patients with any advanced cancer, at least as initial treatment. The last question I would like to pose is, does empiric chemotherapy, one therapy for all CUP patients, still have a role? The answer by and large is no. However, there is still a role in those patients who have very unresponsive cancers, as I mentioned earlier up here in reference to site-specific treatment. However, for many patients now, probably 1/2 or greater, we know that treatment can be better when it's site-specific, i.e. we treat as breast when we have diagnosed breast cancer, even though they present as CUP. We treat as lung when they're diagnosed as lung cancer, renal when they're diagnosed as renal cancer, etc. On the other hand, pancreatobiliary cancers, we don't think we can make any headway with site-specific treatment, and it's no better than empiric chemotherapy. Now, we've learned over the years, based upon using immunohistochemistry as well as the cancer type ID, that there are some subsets where a specific diagnosis is very important, even though they have CUP. And we've published on this, and others have too. These include colorectal subset, the renal subset, lung subset, germ cell subset, neuroendocrine tumors, melanoma, which at times is called carcinoma, ovarian cancer, breast cancer, urothelial cancer, or poorly differentiated cancer without an established lineage. All of these are important in terms of presenting as CUP and being highly treatable once they're recognized. When treated with site-specific therapies for cancer types diagnosed by cancer type ID, the outcome appears the same as those with known primary sites treated with the same therapies. In other words, finding what type of cancer a patient has is very important because you want to give them precision therapy. Colorectal presenting as CUP is now included formally as a favorable subset in patients with cancer of unknown primary site. And this is now recognized basically around the world, published information. Lung and renal cell can be added to the list in that when renal cell presents without an obvious primary site in the kidney, otherwise diagnosed by cancer type ID and or immunohistochemistry, one can see the same results with targeted therapy and immunotherapy as with known metastatic renal cancer. And I mentioned poorly differentiated cancers of questionable lineage. The pathologists aren't sure what type of cancer they have. The cancer type ID is very useful in this setting, and we've published on this, although this is a relatively rare entity. Now, can we improve the prognosis of patients by learning what type of cancer they have when they otherwise have CUP? I mentioned this earlier. In some patients, we clearly improve the outcome. When looking at all the patients that we entered into a study a few years back, over 200 patients with CUP, and treated with site-specific treatment and compared to historical controls, there was an overall survival benefit measured in about 3 to 4 months. However, there was much better survival in those with more sensitive cancer types than those with the more poorly responsive cancer types, as I mentioned earlier, such as biliary tract cancer and pancreatic cancer and advanced squamous cancers. This is even more evident now because we have even better therapy for some of these sensitive cancer types, including targeted drugs and immunotherapy with immune checkpoint inhibitors. The cancer type ID can determine the cancer type by identification of gene profiles associated with normal tissues that are typically retained by cancers. So that's the key to determining the cancer type. It does not look at genetic alterations in cancer cells. On the other hand, comprehensive molecular profiling can determine various genetic alterations in cancer cells, but cannot thus far accurately, with validation, determine the cancer type, except one rare exception in prostate cancer, where a certain percentage of patients with advanced prostate cancer have this fusion, this TMPRSS2-ERG fusion, which can be detected by next generation sequencing. Very rare, but nonetheless interesting. Now, how do we integrate the cancer type ID and comprehensive molecular profiling in patients with CUP? There's one important premise. Optimal treatment for CUP is based on the diagnosis of their cancer type. Some cancer types, which are less sensitive to site-specific therapies at this time, do as well with empiric chemotherapy, although both of these groups do poorly. Therefore, in that group of patients, learning the cancer type is not nearly as important as the group of patients that have sensitive cancer types. This is changing all the time, so keep this in mind. In patients with CUP, when a likely diagnosis is based upon classic immunohistochemical profiles, further evaluation and treatment can be based on this diagnosis without additional molecular testing, particularly of the cancer type ID. However, only about a third of all CUP patients fit this category. Further molecular testing for many cancer types, particularly those patients who do not have immunohistochemical single diagnosis. We need the cancer type ID in order to make a single cancer type diagnosis. Now, in this group of patients, we often recommend next generation sequencing because there can be specific abnormalities which can be very useful, particularly as second or third line therapy. Most of these therapies determined by next generation sequencing have not been approved as first line therapy, except for rare instances. In CUP patients without a single diagnosis by IHC, representing 2/3 of all the patients, a cancer type ID is the most important first test to obtain to determine the cellular context or the type of cancer the patient has. Further molecular testing in the form of comprehensive molecular profiling or next generation sequencing in some cancer types particularly may lead to important therapy, particularly in second or third line settings. Now, it's important to determine the cancer type first. And in other words, don't put the cart before the horse. Cellular context remains very important and likely to be so for many years to come. When looking at a patient with CUP, cancer type ID, sometimes combined with immunohistochemistry, can give an accurate diagnosis of the cancer type. In some patients, then, depending on the cancer type, and we'll illustrate this in a minute, biomarker profile-based treatment becomes very important for particular cancer types. I mentioned lung earlier, but there are many others, including breast, melanoma, colorectal. And then a personalized treatment plan for that individual patient can be formulated. What about challenging diagnostic cases? Many patients with CUP are like this. And there's a tendency for many pathologists to exhaust the available biopsy. And this is an algorithm that I think is reasonable to follow. When a patient has a biopsy and has an unclear diagnosis, it's important to do a cancer type ID. Often, if 3 or 4 slides are reserved, and you only need 300 to 500 cells to do the cancer type ID, this can be done later as necessary, or it can be done on the front end. But this way, one can do it later. And then biomarker tests for specific targeted therapies can be done either by spot molecular testing or, in my opinion, more comprehensively by next generation sequencing. And then after one has the cancer type, as well as biomarker information, then precision therapy can be given to many, many patients. Let me give some specific examples. A patient with CUP who has adenocarcinoma and has by immunohistochemistry a classic lung profile, and here it is, and a serum thyroglobulin, which is negative. The reason you want that is this classic profile can also be present in metastatic thyroid cancer. That's a rare cancer. Adenocarcinoma of the lung is a common cancer. So a serum thyroglobulin would almost always be positive in thyroid. So in this instance, it's negative. In this case, you want to evaluate for known actionable accepted targets. I mentioned a few earlier in lung cancer. In this instance, first-line treatment can be given in this setting for various markers such as EGFR mutations, ALK or ROS1 rearrangements, and a few others, which are becoming now more recognized. So in this case, one has a diagnosis by immunohistochemistry. As I mentioned, if that is true, we don't need, in that case, a cancer type ID. On the other hand, many patients with adenocarcinoma, the immunohistochemistry is inconclusive. Often they have a CK7, which is positive, which can be in many different cancers. In this case, for instance, the cancer type ID is very important. In this particular case, breast cancer, 96% probability. So that once again triggers you into doing some additional testing. This can be confirmed. In this case, mammoglobulin was positive, as well as a GATA3, which confirms or corroborates the CTID diagnosis of breast cancer. Further molecular test, in this case, for breast cancer with HER2/neu, or preferably next generation sequencing, may find other important abnormalities that can be treatable in this particular CUP patient. There are many other examples. Once one knows a specific cancer type, one can then plan more precise therapy or look at more precise genetic testing, such as next generation sequencing. Melanoma, thyroid cancer, renal, ovarian, germ cell, prostate, basal cell, urinary bladder, neuroendocrine, and others. The list is growing as more important treatments are developed. Now, I want to illustrate that the size of the primary really doesn't make any difference. All these patients that I'm going to illustrate to you are all the same age. They all have metastatic disease. The first patient has a right lung mass and has liver lesions. A liver biopsy shows adenocarcinoma, and the patient has a classic immunohistochemical profile of lung cancer. A thyroglobulin was done, which was negative. This is stage 4 adenocarcinoma of the lung. The patient has a primary in the right lung. Here's a second patient. 60-year-old man, has abdominal pain and weight loss. This patient has a huge right lung mass, 15 centimeters, has liver lesions. A biopsy shows, once again, the classic pattern of lung cancer, thyroglobulin negative, If this would have been just CK7 positive without TTF1 or NAPSIN-A, one would want to do and need to do a cancer type ID, in which case very likely, or let's say for the sake of this patient, is stage 4 adenocarcinoma of the lung. Further testing and treatment should be considered for lung, and this would include in molecular testing looking for the targets. The third case is a 60-year-old man with abdominal pain and weight loss. In this case, there are no lung lesions seen. Liver biopsy once again shows the classic pattern for lung cancer, thyroglobulin negative. The conclusion, this is advanced stage 4 lung cancer. Further testing and treatment as such. Notice this patient did not have an obvious primary site. This is a CUP patient who, after further evaluation, clearly has lung cancer. Cancer type ID could be used in concert with immunohistochemistry, particularly when there's not a classic pattern, which, as I mentioned, is fairly common even in lung cancer. What about the changing nature of CUP? This has recently been appreciated. As I mentioned, CUP represents metastatic cancers from many small or occult primary sites, about 30. This is a unique aspect, yet unexplained, of all CUP patients. This is not a single disease. This represents metastatic disease from a very small, clinically undetectable primary. The response rate and survival associated with appropriate site-specific therapies once the cancer is diagnosed and treated as such is the same as metastatic cancers with known anatomical primary sites. Some of these are responsive cancers that do quite well, others are not. The population of CUP is changing since many patients felt to have treatable responsive cancer types based on improved immunohistochemistry are treated as such and not considered, quote, as CUP, unquote. Yet no anatomical primary site is found. I mentioned several of these subsets. You can imagine if one is doing a study with CUP and clinical oncologists are excluding these treatable subsets of CUP from the study, they are in fact including only those with relatively untreatable cancers. And that's what's happened in one major recent study. Clinical trials are skewed to the less responsive cancer types. Now, here's an example where molecular classification helped guide treatment, and it was confirmed by immunohistochemistry. A patient with a retroperitoneal mass and bone lesions, no obvious primary site, CT scans normal otherwise. Biopsy showed a poorly differentiated adenocarcinoma. The immunohistochemical findings were nonspecific, and the primary site was indeterminate. A cancer type ID showed renal cell carcinoma with a 96% probability. The pathologists were asked to do some renal cell stains, which were not done initially. You can't do all immunohistochemical stains on every biopsy. But in this case, a renal cell carcinoma stain, an RCC, that's a specific stain, and a PAX8, which is frequently positive in renal cell, were positive. Therefore, that corroborated the CTID diagnosis of renal cell carcinoma and gave confidence to the oncologist in the treatment for this CUP patient as renal cell carcinoma. Let's talk about a second case, again with some redundancy. This was a 45-year-old female with no history of smoking. A chest CT revealed a large mediastinal mass and pleural effusion. Biopsy of the mediastinal mass was metastatic adenocarcinoma with signet ring features. This often means it's from a GI source, but as you'll see, not the case here. Clinical evaluation of the metastasis revealed only a left adrenal nodule. It was very small and felt to be an adenoma, not a metastasis. After extensive imaging, including bronchoscopy as well. The patient was diagnosed with adenocarcinoma of unknown primary site. She was treated at that time without further evaluation with a lung form of treatment, pemetrexed, carboplatin, and concurrent radiation. You can see her marker studies over here. The CK7 was positive, and this breast cancer marker was also positive. The cancer type ID showed that this was lung adenocarcinoma with a 90% probability. I just want to go back here for 1 minute. Notice this breast marker was positive. This is not specific for breast cancer. And although one would be suspicious if one had CK7 and this GCDFP5, 15, this is 15, positive for breast, but cancer type ID settled this issue. This is lung adenocarcinoma. Now, in this particular patient, additional testing showed that this patient had an ALK rearrangement, one of the relatively rare rearrangements in adenocarcinoma of the lung that can be treated initially with targeted drug. In this case, an ALK inhibitor. At that time, crizotinib was the only treatment for such a patient. She responded for 30 months on this treatment. A second case, getting back to this confusion rarely with thyroid cancer, this was a 68-year-old man, previous smoker, had left arm pain. An MRI showed a lesion in the left upper humerus. CT scan of his chest and pelvis was negative. He had a bone biopsy, revealed adenocarcinoma. This was felt by the oncologist to be lung cancer. The reason being it was CK7 positive and TTF1 positive and CK20 negative. That is a classic triumvirate, if you will, 3 stains, classic for lung cancer. Keep in mind, however, thyroglobulin needs to be checked in this case to be sure it's not thyroid cancer. This particular patient had a cancer type ID and, in fact, a 98% probability of thyroid cancer, follicular papillary type. This is rare to present as metastatic disease, much less common than lung cancer, but the serum thyroglobulin was greater than 1,000. He did have next generation sequencing looking for some classic abnormalities in thyroid cancer, but none were found. He had radiotherapy to the left upper arm and had radioactive I-131, which has now been administered, continues to do well clinically. A third case is well-differentiated neuroendocrine tumor in the liver of unknown primary site. A 31-year-old woman, abdominal pain, CT scan revealed a right liver mass. Core biopsy, well-differentiated neuroendocrine tumor or carcinoid with classic markers. A dotatate scan was positive only in the right liver mass. A cancer type ID showed a 94% probability of an islet cell tumor. She had the liver lesion removed. There was no obvious evidence of a pancreatic tumor, which is an islet cell carcinoma or islet cell tumor. But 3 years later, she was reevaluated and a gallium PET scan showed a small lesion in the tail of the pancreas. Surgical removal of this showed the primary, which is a well-differentiated neuroendocrine tumor. She didn't have any obvious primary site. It was too small to find 3 years earlier. It was found and this was removed. She continues to do well. So there are some important issues or nuances with cancer type ID. I only am going to mention a few. There are some cancers which are not recognized by cancer type ID because they're not in the panel of cancers that was studied initially with this important assay. Rare cancers or those with mixed histology, such as adenosquamous, can confuse cancer type ID. or those that have scar tissue in the cancer itself, which is some cancers in sight. These can be called sarcoma, even with laser dissection. The rare cancers that aren't in the panel may be called some other cancer. An important cancer that's not in the panel is anal cell squamous cancer. And therefore, most of the time, will be called squamous cancer, but because anal cell's not in the panel, it'll likely call it one of the other squamous cancers that are in the panel, such as lungs, skin or head and neck, or uterine cervix. There can be overlapping diagnoses by cancer type ID. And I'll just mention a few here. Pancreatobiliary, including pancreas, bile duct cancer, and gallbladder frequently overlap. And head and neck, skin, and squamous cancers are indistinguishable. They cannot, so one has to use other clinical and pathologic features. Breast and salivary gland overlap. So it's important to understand some of these. And you can look here. There are some other rare examples. Bladder cancer. Bladder cancer or urothelial carcinoma is an important group of cancers. It's important to recognize that the ureter and the renal pelvic areas are also urothelial cancers, but those are not in the panel recognized by cancer type ID. Therefore, a cancer of the ureter or renal pelvi, which are not rare, particularly of the renal pelvi, will be called bladder cancer by cancer type ID. That's okay. If you recognize this, you can have other clinical features which may allow you to know that the patient has a urothelial cancer, even though there doesn't necessarily in the bladder. This issue of having a probability of less than 70% is important. It may be a cancer that's not in the panel, or it could be an accurate diagnosis, particularly if it's close to 70%, like 68 or 69%. A totally wrong cancer type diagnosis is rare, less than 2% of the time. Now, there are many other examples where cancer type ID can be very useful, particularly when a rare cancer happens to be in the panel. This is the case with metastatic basal cell carcinoma. I've seen a few of these patients. In this case, a 58-year-old man with back pain and left inguinal adenopathy with a bone lesion. CT scan showed bilateral lung nodules as well as a retroperitoneal and inguinal adenopathy and lytic bone lesions. Biopsy showed a poorly differentiated carcinoma. This was cancer of unknown primary site, the cancer type ID, 96% skin basal cell carcinoma. Many oncologists wouldn't believe this diagnosis because this is rare. This patient had next generation sequencing and in fact had the classic mutations of this hedgehog pathway, which is classic for basal cell carcinoma. He was treated with a hedgehog inhibitor, which is on the market for precisely this reason, and his back pain resolved after 3 weeks, and he did well for 35 months before progression. Interesting case of a rare cancer diagnosed by cancer type ID with important therapeutic results. Here's an example of melanoma that was initially felt to be carcinoma. This is not that rare. Patient was 62 years old, cough, multiple bilateral lung nodules. A percutaneous biopsy showed a poorly differentiated cancer. Many pathologists thought it was carcinoma, but they weren't sure. Cancer type ID was done. Immunohistochemistry was not helpful. 90% melanoma. Next generation sequencing showed the classic mutation seen in 50% of melanoma patients, V600 BRAF mutation. Patient was treated with a BRAF inhibitor and did well for 18 months, subsequently progressed and then did well with immunotherapy for 16 additional months with an ongoing response. Now, I'm about ready to finish here. Excuse me. There have been 2 randomized studies to determine whether site-specific treatment based on a molecular assay could improve outcome. The first was from Japan, and they used an in-house assay, not the cancer type ID. This study did not show any difference. It was small, phase 2. Notably, 20% of the patients had lymphoma, which is amazing because this can usually be recognized by immunohistochemistry, and therefore makes this study suspect to begin with. It was too small and not conclusive. More recently, published in abstract form only, is a European study which had a better design, but it has many issues with it as well. 243 CUP patients. The majority had a cancer type ID. Initially, they had an earlier molecular cancer classifier, but that test was no longer available. So cancer type ID was done in the majority of these patients. And then they received site-specific treatment based on the cancer type ID diagnosis, or they received empiric chemotherapy with gemcitabine and cisplatin. Now, the majority of these patients had insensitive cancer types. 70% had pancreatobiliary or squamous cell with advanced cancers based on the cancer type ID. Why was that? Well, it's likely for the reason I mentioned earlier, that oncologists, when they have clinical or pathologic evidence, particularly by IHC, of a more treatable cancer type, they're less likely to enter their patient on this type of study. The other thing is this study was designed a decade ago, long before targeted therapy or immunotherapy was even being used. So none of these patients received those more effective therapies. If they looked at just the 60 patients that were felt likely to be insensitive to the empiric treatment, so only 60 of these 243, 37 received site-specific treatment and 23 were randomly allocated to gemcitabine and cisplatin. This was randomly done. This group included renal cell, colorectal, breast, melanoma, neuroendocrine, liver, salivary gland, and sarcoma. Why the latter 2, I'm not sure. They're pretty much insensitive to any of the empiric therapy. Maybe that's why they were included. But these patients, they did better when they got site-specific treatment. 60 of these, at 1 year, 39% were alive who got site-specific treatment versus 30% who didn't. But more importantly, at 2 years, more than twice as many were alive who got site-specific therapy. Keep in mind, the site-specific therapy was not immunotherapy or any targeted therapy. So by today's standards, it's likely these survivals would even be better. But this was too small a subset to be statistically significant. So this type of study does not really give us the answer we need. It does support the fact that more sensitive tumor types are likely to do much better when given site-specific treatment than the less sensitive tumor types, which I've mentioned previously.